Good day. This is De Wet Swanepoel. I am wishing all of you a wonderful World Hearing Day for 2023. I am a professor of audiology at the University of Pretoria in South Africa, which is also a WHO collaborating center for the prevention of deafness and hearing loss on the African continent. And I'm just going to share today along some of the background on ear and hearing care for all, and then share with you some of the projects that we have done and are continuing with on the African continent to really see this vision of ear and hearing care for all come to light. So the theme of this year's World Hearing Day, promoted by the World Health Organization, is on ear and hearing care for all, and let's make it a reality. So that's really the focus and the emphasis of this year's public awareness drive, with the strapline of primary health care that can address over 60% of the need for ear and hearing care services globally. So the WHO has wonderful resources available for those who want to utilize these resources to also promote World Hearing Day and ear and hearing care for all. Here are just some of the examples of these resources available on their website. There's a stepwise approach to check ears and hearing that can be used in primary healthcare settings that gives step-by-step instructions on how to check ears and hearing in these primary healthcare settings for babies, children, adults, and older adults, and provides a very simple outline. There's also brochures available. To your right, you can see the brochures on looking out for hearing and language milestones and how to act early, with wonderful milestones on the back of that document as well. And those are just some of the examples of the tools that the WHO has made available. Just a quick acknowledgement of the various partners that have been involved in the work that I'll share with you today. So we have a number of investigators that have been very involved in the research that I'll be presenting. We're fortunate to have a team of collaborators from all over the world. We are also funded by the NIH, the Newton Advanced Fellowship, and have also received funding from Sonova for supporting this project through the Year the World Foundation. I'd also like to just acknowledge the fact that I am a co-founder and a scientific advisor of the YearX group, and I will be sharing some of the technologies that enable the community-based models that we'll be looking at in this presentation. In terms of the outline, I'll briefly give a bit of background and context again on the status of hearing loss globally, according to the World Report on Hearing that was launched by the WHO. And then we'll look at two examples of reaching underserved populations in Africa. We'll look at a community-based hearing screening project facilitated by lay health workers using mHealth technologies. And then we'll look at an adult community hearing care model, also utilizing community health workers, utilizing mHealth technology to provide a full service comprehensive model from testing right through to providing hearing aids. So if we just briefly consider some of these influences, so the World Report on Hearing has called for hearing for all across the life course globally as a call to action. The report highlights the prevalence of hearing loss, indicating that 1 in 5 people globally live with hearing loss, and that by 2050 it will increase to 1 in 4. 430 million of these require rehabilitation services currently, and that will increase to 700 million by 2050. 80% of these persons, however, reside in low and middle income countries where access to services are very limited. And we know that unaddressed hearing loss impacts many aspects of life, generally and specifically. And the WHO has modeled these effects of untreated hearing loss and came up with an annual price tag of unaddressed hearing loss of $980 billion every year. So most people with hearing loss, we know globally, don't have access to treatments, and that can vary from 74 to 91% of people with hearing loss. And this report highlights hearing across the life course is important to include prevention, early identification, and appropriate care. One of the major challenges is still inadequate human resources professionals to provide hearing care. So there's a big emphasis on task shifting to minimally trained persons to deliver portions of the hearing care delivery pathway. A strong focus also on community-based models. But importantly for us to highlight here is that there's also included in these recommendations the highlight of using teleaudiology and telemedicine to make hearing healthcare more accessible. And that includes things like innovative screening and test technologies that are required. Here we have the first project I'll be sharing, a community-based hearing screening project that provides hearing screening in communities to young children in low-income communities, provided by minimally trained lay health workers utilizing mHealth technologies to support the screening services, particularly for hearing, but this project also combines screening for vision. And of course, we know that healthy hearing and healthy vision is the gateway to healthy learning. It's these two senses that are the gatekeepers for successful education and that lays the foundations for later life successes in employment and making a contribution in society. So in terms of childhood hearing loss and the prevalence, I thought to put up this slide from the Lancet Global Health paper that came out 2018 that just shows a global picture of the prevalence of childhood hearing loss. And you can see that the majority of high prevalence countries are based in Africa, with prevalences from between 3,000 to 3,500 per 100,000 children. So that's 3 to 3.5 per 100 children under 5 years of age. So very common. This includes all types of hearing loss. We know that 60% of these, according to the WHO, are due to preventable causes. But the reality, of course, is that in a continent like Africa, where such a high prevalence rate is evident, there is very poor access, with hearing care professionals less than 1 for every 1 million people on the continent of Africa. So there's a massive disparity there. So this is also a priority area for the World Hearing Report. Early identification, which is a key element to successful outcomes in persons with hearing loss, and innovative screening solutions and teleaudiology and telemedicine are key factors identified by the WHO to make this widely available. The reality is that there is a number of significant barriers to early detection of hearing loss in young children, especially in low and middle income countries. I'm listing some of those barriers to the left, but the digital technologies are enabling ways to address many of these barriers. For example, task shifting with automation and AI is addressing the limited professional hearing healthcare professionals available. Improved affordability with digital technologies can address the expense of traditional equipment. The mobile point of care nature of digital technologies can mean we can decentralize services. And then the use of sensors, algorithms, and rigorous quality control metrics in these digital technologies can support quality control when we take services outside of clinics. And then integrated cloud data and referrals can address the lack of good data management and surveillance in screening programs. Here's a model for community-based screening that we've been using in several communities for tens of thousands of children over the past few years. So you can see on the first illustration, we've got a community health worker who is sitting with a child. They've used a mobile device to map facilities in the communities, early childhood development centers and schools, and they can then go and provide services in these schools to young children. They use the same device to do hearing screening and also visual acuity screening. We'll get to the technology in a moment, but after the test is conducted, it uploads to a server and a text message is then sent out to the parents on the outcome of the screening for vision and hearing. If they fail, based on geolocation, they're linked to the closest public health service for diagnostic services and potential interventions. There's also a diagnostic set of equipment at these facilities so that when they get there, we can then track that someone has actually attended a follow-up appointment, which really allows us to measure the impact of these programs also. In terms of the technology that enables this, we use the HearScreen peer tone audiometry screening solution with calibrated headphones. There's an app running on a mobile phone or on a tablet. It's been widely studied and demonstrated to be accurate. It's also very time efficient, and because it's on mobile devices, it's cost effective, and it employs rigorous quality controls, including measuring the environmental noise in real time during the test with the microphone of the device. And because it's such a simple user interface with automated test sequences and protocols, laypersons with minimal training can actually operate this. And then all the information from the mobile device is synced back to a cloud-based portal where hearing care professionals can remotely monitor the outcomes of the screening program and provide the necessary interpretations when needed. So this approach is also highlighted by the World Report on Hearing. There is a section on using community health workers with mobile digital technologies to offer screening. Here's an example, a picture actually from one of our screening programs where a community health worker is using this HearScreen technology to screen hearing in this young boy. So importantly, we want to also make sure we know that when community health workers are offering the screening, that they can provide a reliable service. So here we have just two papers that I'm highlighting. The first is from 2021, published in IJA, that looked at mHealth hearing screening by non-specialist health workers in communities, and it compared results between professional school health nurses, and we found no significant effect on the screening outcome whether you were a community health worker or a professional nurse using this technology. Another study by Tess Bright in 2019 looked at the diagnostic accuracy of non-specialists versus specialist health workers in diagnosing hearing loss and ear disease in Malawi using the same technology but the diagnostic version, and their results found that non-specialists can accurately assess hearing using the ear test, which is the diagnostic version of this app-based audiometry solution. So it just illustrates that community health workers can utilize these technologies reliably and accurately. Very briefly, I mentioned that there's also a visual acuity screening offered on the same device. So it means the same community health worker, the same device, can also do vision screening very rapidly. It's integrated into the same platform so that we can look at eyes and ears using this technology. There's a couple of validation papers already published. Let me just highlight this one from the WHO bulletin that came out a few years ago, and the conclusion of using this technology was that mHealth supported hearing and vision screening facilitated by community health workers can enable access to care in communities within accepted performance indicators, including things like follow-up return rates, diagnostic referrals, false positive rates, and it can be done at low cost. So here we have a model where we're delivering adult-based services in communities, in low-income communities. So we've got 5 steps to this model: detecting hearing loss, diagnosing, demonstrating hearing aid benefit, and then treating with hearing aids and providing support remotely. So you can see in the blue on top, community health workers are the primary agents delivering this care in communities. In pink at the bottom, we're just stating that healthcare professionals are supporting this model remotely. They're also providing the training, but also the support throughout remotely with telehealth technologies. And this entire model is mHealth enabled. So it's mHealth technologies that are making it possible to deliver this service. Here we just illustrate the mHealth technologies that are making this model possible. We've got the Ear Screen technology for screening, as I mentioned. We also use the Ear Scope, which is the video otoscope that plugs into this mobile phone and uses the AI to classify the types of conditions to help with triaging. And then we use a hearing aid called the Lexi Lumen hearing aid that's connected to a mobile application to provide the service in this community. So just to say 1 or 2 things about this hearing aid: it's a low-cost, high-quality, self-fitting hearing aid. It has 18 channels, wide dynamic range compression. It's also Bluetooth enabled, which is very important for this model, and it has adaptive directionality and noise reduction. Importantly, when we deliver services in the community, we want something that can also provide amplification to a wide range of hearing loss. So this serves for mild to severe hearing losses. But importantly, it's digitally integrated with the mobile platform. So it allows us to do smartphone-based in situ pure-tone audiometry for patients and using an automated test sequence. But importantly, then from the mobile phone, we can immediately do a hearing aid fitting through Bluetooth according to the NAL NL2 fitting algorithm, and it allows for data logging as well. So this project, as I mentioned, is community health worker enabled. We like to refer to it as a high-tech, soft-touch approach. It's high-tech because we utilize innovative new technologies, but it's a soft-touch approach because we use community members to facilitate the service in community settings. And just to mention a couple of prior work that's been conducted, there's a study in 2021 that looked at mHealth hearing screening by non-specialist health workers in communities. And this study found that professional nurses using the same technology compared to community health workers showed no significant effect on the screening program outcome. So it just means that minimally trained persons through task sharing can actually provide screening on par with professional nurses and other professionals. So there's another study by Tess Bright that came out in 2019 that looked at the diagnostic accuracy of non-specialist compared to specialist health workers in diagnosing hearing loss and ear disease in Malawi using this same technology. And in this evaluation, they found that non-specialists could accurately assess hearing using this ear test application for audiometry on par with professionals, including audiologists and physicians. So the technology enables use by these minimally trained persons. So the first step in the model is to detect hearing loss. So this is done through different ways. So we can do community screenings with the mobile technologies, but it can also be through primary healthcare clinics and pharmacies or referral networks from community networks where it's through self-report. The way in which we then use these technologies operated by the community health workers to diagnose hearing loss, a limited diagnostic service, is we do in situ hearing testing. So the community health workers have a pair of test hearing aids that they put on the person's ears. They then cover them with Peltor ear muffs to facilitate the hearing test. It means we have a attenuation factor that's similar to a single-walled soundproof booth. And then we do an audiogram, typically 4 frequencies from 500 to 4,000 hertz. That's facilitated by the community health worker. It's literally just a response button that the patient presses, and it runs automatically from there. But then we also triage through looking at the configuration and the degree of the hearing loss, and identifying potential conductive hearing loss and ear disease using the ear scope. And we also screen for asymmetric hearing losses that are at risk and require further screening. So very briefly, just to illustrate the accuracy of in situ audiometry, it's been used very widely previously. There are many publications. We also evaluated this technology and found that it was very accurately correlated to conventional piezo audiometry, with 93% of thresholds corresponding within 10 dB of each other. So here you can just see an illustration where a community member in her own home is being provided with the test hearing aids on your left. Then the peltors are covering her ears in the middle picture, and she's pressing the button whenever she hears the tone. And on the right you can see the test results with thresholds from 500 to 4000 Hertz in the left and the right ear. And at the bottom there's a simple button that just says set up my hearing aids, and when that is pressed, the hearing aids are set up through Bluetooth using the NL2 fitting algorithm, so the patients can immediately experience the benefit of amplification. So I mentioned that we're triaging also with the ear scope. There you can see to your left the patient's ear canal and eardrum is illustrated there, and the AI provides an indication of whether this patient actually needs to be referred to a local clinic. So the digital AI otoscopy through the ear scope, here's just some examples of what it looks like when you take an image. On the top left, an image was taken of the ear canal, and here you can see there's a wax obstruction with 100% confidence that this is truly a wax obstruction. Below it, there's a picture of a chronic perforation, and the AI provides a 96% confidence level that this is a chronic perforation. To the right, the top right, we have a normal tympanic membrane classified as 99% normal, and then there's an abnormal category right at the bottom. Importantly then, based on the information here, those individuals that have normal hearing can continue along the service delivery pathway or normal tympanic membranes. Those with chronic perforations or falling in the abnormal category typically require additional treatment, medical workups. Those with wax obstruction could, at a primary healthcare setting, actually get wax removal or management done. So there's a bit of a triage process that can happen based on these results. And here we see just the demonstration step 3. So as soon as the test is done, we program the test hearing aids, and they can immediately experience the benefit of hearing aids. And in this pilot, we ran this elderly lady, when she was hearing for the first time with the hearing aids, her first response was, "It is as if I'm able to see, everything is clear." And we've seen a tremendous benefit from actually demonstrating in their own environment immediately the benefit of a hearing aid. The responses have been overwhelming, and then they can then select or choose to take up a device, and then a new pair of hearing aids is fitted, and the community health worker just presses the fitting button again based on those thresholds. But we know it's not just about providing a hearing aid, so there's also support that needs to be provided. So the community health worker is providing the support by providing batteries, keeping the disposables that's necessary, troubleshooting, doing device care, and information provision and questions as necessary. They typically do this through SMS or WhatsApp. And they can also connect to the audiologist, the program manager, remotely if anything is something that's beyond their expertise to provide input on. So the audiologist is remotely providing care in an asynchronous manner. Importantly as well, there's a support program that's provided through mHealth to these individuals who are getting the hearing aids. So these are text messages, or they get them through WhatsApp typically, and it's about adjustment, handling, maintenance, cleaning, and other psychosocial factors. The content is little info bites like the one you see on the right. So it's information about how to wear your hearing aids correctly, but there's a voice note that accompanies this. So as they look at the info bite, the voice note's about 2 to 3 minutes, is playing and talking to them about how to take care of their hearing aids. And they're scheduled over a 6-week period. The first week they get them every day, and then they get less frequent with subsequent weeks. So these have been very effective in the service delivery model we've rolled out. In terms of evidence for this model, we've published the first paper looking at this community-based adult hearing care provided by community health workers using these mHealth technologies. And it's just come out in Global Health Action. Happy to share this with you if you're interested. And the paper on the hearing aid acclimatization program provided through mHealth is almost ready also to be sent out for peer review. We measured the outcomes on these in first batch of 19 patients at 45 days and 6 months post-fitting. It was patients from a low-income community. And you can see here that we've got the IOI-HA outcomes. So the maximum best outcome is a 5. And we can see that the outcomes over all the 7 categories of the IOI-HA is really very good, and it was retained at 6 months, which is very encouraging in terms of the outcomes actually being maintained over time. Looking at the mHealth support program outcomes, 78.9% of the participants received the support program via WhatsApp, 21% via SMS or text message. The participants described the program as helpful and supportive and informative, and that they indicated that it was sufficient and it was clear. 5 of the participants reported minor issues with the hearing aids that could all successfully be addressed by the community health workers over a telephonic call or through the WhatsApps. Most of the participants receiving the WhatsApp messages said they preferred the voice note component as part of this support program. And the mHealth program was found to be feasible, and that it just lends itself to a scalable self-management of first-time hearing aid users in low and middle income country settings. So this service is currently being rolled out in Kenya as well through primary healthcare clinics. 5 clinics have just started in July 2022, and it's a subscription model with mobile money, and it's inclusive of support and batteries where patients can actually subscribe to bring down the cost and make it more accessible and affordable for individuals in lower income communities. So just to conclude, the World Hearing Day initiative, shedding the light on ear and hearing care for all, making it a reality, is a wonderful initiative by the WHO to spotlight the importance of ear and hearing care, but also to provide wonderful resources. The examples that we discussed and we looked at during the course of the presentation provide a novel approach to address the massive inequality in terms of unaddressed hearing loss and the poor access to hearing care professionals. There's a big gap, and we need to think of new ways utilizing task shifting, but also innovative technologies to enable hearing care for all. And I hope these examples provide some insights on how these could be developed into the future and scaled to larger groups of individuals. Thank you very much for the opportunity to share with you. I've left my contact details there. Feel free to contact me if you need any further information, and have a wonderful World Hearing Day.